And again, it's important to align what matters with the older adults to the benefits and harms of various screening tests. And so if you want a little deeper dive into what and how you evaluate what matters to the older adults, there's a very good toolkit that's listed on the Institute for Healthcare Improvement website. And this is part of the Hartford IHI, American Hospital Association, an initiative associated with what we call age-friendly healthcare. So I highly recommend that you use this as a resource to consider some tools for yourself. I personally like the Stanford letter, which helps older adults, kind of walks them through with guided questions to answer what matters to them, and then to convey that to their primary care provider. So there's a set of recommendations from the American College of Physicians. So their Choosing Wisely program basically recommends not using PET scans, CT scanning for cancer. I had a commentary by somebody working in a rural area once where the patient said, "Oh, this Dr. So-and-so is great because he's finding cancer all over the place," and everybody's so grateful. And he was doing basically routine CT scanning, whole body scans. And the problem there is that you find the non-malignant tumors, and it causes a lot of morbidity and mortality just from pursuing those kinds of diagnoses. You also want to consider remaining life expectancy relative to the risks of testing and overdiagnosis and overtreatment, which is the same rationale behind not using whole body PET or CT scans for screening healthy individuals. The recommendation for Choosing Wisely is that you get your colonoscopy, and if it's pretty much normal, you go each 10 years thereafter. And so that's sort of their recommendation. Obviously, if somebody has polyps or a biopsy, and if the gastroenterologist recommends a 5-year follow-up, that certainly makes sense. The other one is dialysis patients. So pretty much they have a 7-year lifespan. That's pretty much absolute once they start dialysis, and usually it's much shorter than that. So they don't meet that criterion of a 10 years or greater lifespan that would warrant further cancer screening. So I want to ask questions a little bit here about the Welcome to Medicare exam, and we want to look at the annual wellness exam. So the Welcome to Medicare visit has various components. They're basically, on the left side here are the assessment part of it, and on the right side are the action plans. And so many of these are straightforward. They're just like a regular HPI and physical exam. So you want to look at the past medical and family history, surgical history. Minimally, you have to measure blood pressure and BMI. However, we like to measure other things such as pulse oximetry with walking and gait speed, which we'll talk about. But also in terms of the screening process, so vision and hearing are required. Using the mini-cog for cognition would be great. You can use other tests for screening memory loss. Depression screening, again, would be PHQ-2 or PHQ-9. Geriatric depression scale would also work. You want to look at functional ability, so that they have any deficits in their activities of daily living or instrumental activities of daily living. And you also want to assess for safety. So, traditionally, usual clinical practice, we would say, do you wear seat belts or do you wear a helmet while you're biking? But in geriatrics, you want to ask, have you had any accidents while driving? Have you had any tickets or near misses or citations? Has anybody shouted at you to watch out while you're driving? These are all indicators that there might be some driving impairment, either associated with dementia or neurosensory problems. And then it's important to for the action plan for the Welcome to Medicare to create a schedule for current and future screening services. You want to also include some educational and try to personalize it. There are different techniques that you can use to identify goals. One is called target practice, and so you ask the patient to point out on this target to list what's in the bullseye, what's most important to you there, and then moving out to the periphery for things that you might want to address down the road at a later point in time. The annual wellness exam basically is outlined here with all the different elements that I just talked about. Also, you need to include medication review. Interestingly, they require you to put down all the providers that the individual is currently working with, and so that includes both specialists and primary care. Presumably you as a primary care provider are that individual. However, they want to know all the specialty care, the ophthalmologist, the cardiologist, and so forth. We talked about the geriatric components of memory assessment, depression screening, and fall risk by doing gait and balance exams, and we'll talk a little bit about what those consist of. Lifestyle changes, and then finally talking about advanced care planning. That all this creates a personalized health prevention plan. In terms of health risk surveys, so these are just some recommendations. You can measure quality of life. There are tools for doing that. You ask about general health. Nutrition, hearing, sleep. Sleep is an important one because nearly 1 out of 4 to 1 out of 5 older adults have insomnia. You want to do a home safety check and look at their fall risk. I guess I put that down twice here because I wanted to emphasize it. And then also driving issues, as we talked about. In terms of the health maintenance, these are things that we've covered earlier. I just don't want to go over them again. Just point out that the annual wellness exam should cover all these points: vaccination, cancer screening, infection screening, endocrine screening, so diabetes, hyperlipidemia, and osteoporosis. It's also important to include in this evaluation the social determinants of health. So there are some health systems that actually have a checklist for these, and there are various tools that you can use that cover all these different areas, such as financial well-being, if there's any food insecurities, transportation. And a lot of times these questions are asked by the med tech or the nurse prior to the individual coming in for the Welcome to Medicare exam. In terms of physical assessment, some of the important points are to do the blood pressure, height, and weight. I like, in terms of, and I've divided this up into face-to-face meetings in the clinic versus telehealth, and some of the limitations of telehealth versus the advantages. We can talk about, but I've just parsed this out in terms of some of the things that you can do. So, for example, in telehealth, you have to ask about blood pressure because unless there's somebody there facilitating the telehealth visit, the individual, the older adult, would have to check their own blood pressure. I think, importantly, a question to look at is, and to ask yourself as a provider, as to whether the patient looks their stated age. If they look older than their stated age, then chances are that they actually are biologically older. And that's an important indicator for what we talked about earlier with the e-prognosis, or identifying how much remaining life expectancy the older adult may have. In terms of gait and balance, I really advocate gait speed. Anything less than 1 meter per second is considered a risk for falls. Sharp and Romberg is where you put one foot in front of the other, and that's a good balance test for screening for fall risk. In terms of neurosensory exam, Snellen charts, whisper test, and checking for cerumen are important. You can see on the balance of telehealth that you can ask the individual to read a newspaper and report if they have any problems. In terms of neurology, I like to evaluate patients for frontal release signs, so certainly the glabellar test and the snout reflex. Also check for cogwheeling, various sensory elements, including vibratory. So vibratory sense goes down with increasing age. However, if somebody has loss of vibratory sense in their fingers and in their feet, you might consider heavy metal toxicity as an example. And I've picked up a couple of cases of that just by focusing, or including rather, vibratory sense in both the upper and lower extremities. In terms of memory testing, the Mini-Cog or the telephone inquiry for cognitive status, the TICS. You can also use the 88 and ask the caregiver or spouse if there are any indications of cognitive impairment for the patient. Some of the other points that I want to make is in terms of the clinical exam, you want to look for proximal muscle weakness, which might be associated with polymyalgia rheumatica. A lot of times the individual will report that they're having problems getting up the stairs. They have to stop after a couple of steps. And also check for heel softness. This is often overlooked, particularly in the sedentary older adult or the wheelchair-bound older adult. So always check. So the softness is, firmness on the tip of the nose would be normal for the heel. If you feel the side of your nose, that would indicate a softness that would represent a heel unstageable decubitus ulcer. In terms of functional assessment, you want to do the activities of daily living and instrumental activities daily of survey to see if they need partial or full assistance. In terms of functional performance, there's a couple of ways that we can test, like gait speed or the timed up and go test. So the timed up and go test here shown, this is either 10 feet or 3 meters. You walk out to a point and then you walk back, and that all should be done within 15 seconds or less. You can see at the bottom part here, a little hard to read, but just basically the red zones are indications of where slow gait speed, so less than 0.6 meters per second, is associated with functional impairment. And then the next level, it's associated with future hospitalization. And then the third component here, less than a meter per second, is associated with high risk of falls. So gait speed tells you an awful lot, and that's why I advocate using that as the sixth vital sign. So the annual health plan needs to be written. As mentioned, you provide a screening schedule, a health maintenance schedule, what preventive measures are going to occur, and then also to really hone in on what matters, which includes advanced care planning. So just to summarize the annual wellness exam, it's a great opportunity to clarify what matters to the older adult. I mentioned my preference for using the Stanford letter, which I think is very helpful. It's a little long, so you have to have this go with the patient and then they bring it back. Sometimes there's an advanced care planner at the clinic that you can refer to that can help with this. So it's also an opportunity at the annual wellness exam to motivate older adults. So I find that the SPRINT study is very informative. Usually we consider adequate blood pressure control between, basically 140 systolic, but the SPRINT study indicates that if you have a highly functional older adult, that you want to push that blood pressure control even tighter to 120 millimeters of mercury. And so I think that's important to consider. In terms of physical activity, prescribing both resistance, anaerobic, as well as balance training have to go hand in hand with all three of those in order to be effective. In terms of nutritional counseling, I'm an advocate of the Mediterranean diet, and there is evidence that there's better quality of life and also a reduction in brain atrophy over time for those that are in a Mediterranean forward diet, specifically or particularly amplified with fish products. And then also to consider social engagement. So if you got somebody sitting at home and not socially engaged, that could be a trajectory into functional impairment. And so it's important to get the individual out and socialized in some manner, and that may be in discussion with the spouse or with the other family members. So just to summarize prevention, the whole goal is to try to preserve functional independence. There's a lot of the randomized controlled trials on primary and secondary prevention exclude the oldest old, so we don't know a lot. We have to infer from those studies, and again, to balance it with active life expectancy. However, I want to point out that individuals that are 85 and older are amongst the highest percentage of growth in the overall population in the developed world anyways. And so we're going to be seeing people living closer to 100. And so if you have somebody who's highly functional at 75, a lot of these screening measures might be appropriate for those 75-year-olds. So you need to really kind of estimate as to whether this person's going to live 90 to 100 to consider a discussion about further prevention. So there are various sources that we use to help guide us in our preventive measurements. And importantly, we need to balance all of these different kinds of screening tests that we do, particularly cancer screening, with what the functional status is of the older adult, as well as their cognitive status. So if they have moderate dementia to severe dementia, it really doesn't make sense to do a lot of these screening assessments. And likewise, remaining life expectancy. So if you get somebody with 5 or 6 chronic conditions and they're 75 years of age, their remaining life expectancy is barely going to be 78 to 81. So really they're under that 10-year threshold, and you would likely consider not engaging in any type of screening from that point forward. And again, just to really re-emphasize the fact that one of the geriatric 4Ms is what matters, and so it's really very important to hone in and understand what the goals of the older adult are or may be in order to create a patient-centered healthcare plan. So that's the conclusion of this presentation. I appreciate your attention, and I look forward to seeing you on the additional modules that we have as part of this Dakota Geriatrics program to try to enhance geriatric knowledge and skills in clinical practice. Thank you.